Here and
okay.
All right, we are live. So welcome everybody back to another PCBH Corner. I'm super pumped, as I am for most of these PCBH Corners, but particularly that we have Larry Mauksch that's gracefully joined us today and donating some time. So I really appreciate it. Larry, you know, I don't think you need an introduction. I think everybody probably knows who you are, but if you would like to give an introduction, maybe about what your role is currently, any past things you want to highlight, I'll give you some time to introduce yourself here.
Oh, well, my role currently is I'm, for the most part, retired. I still have my hands in a few projects. But by way of introduction, I started working in what was called collaborative care or collaborative practice. Back in 1982, I joined a couple of docs in the Ballard area of Seattle, and I worked with them for 3 years, and then joined the faculty of the University of Washington as the behavioral scientist. And I worked at the residency and in the medical school from 1985 through 2015. And during that time, I expanded my work to be beyond working as a teacher and a clinician to doing research and writing and becoming very involved with Collaborative Family Healthcare Association, helping start it up actually, and I feel very grateful. I've had a very rewarding career and have had the opportunity to work with just so many wonderful people in the field.
You know, and Larry, again, thank you for for being here today. You know, I don't know for people that are watching if they've had the great opportunity to just spend some time with Larry, to talk with them. I know this is corny as hell to say, but you're one of my favorite people to talk to. So it just is. I really appreciate this today. So, you know, the first thing, and I think this is one of the benefits of doing some of these PCBH Corners is that we get to hear what got people into like integrated care, kind of like people's history. And I will say, I've been so surprised, and again, even the last one that we just did with Sandy, about how many accidents there were that just got people into integrated care. So are you okay sharing kind of your history of like, what got you into integrated care and how did that come about?
Well, I don't know if it was an accident or not. I actually come from a family. I was thinking about this. I come from a family with a mother who was a nurse practitioner and a father who was a medical sociologist. And I became a family therapist. And pretty early on, even before I graduated from college, it was obvious to me that I was interested in the intersection between medical and behavioral health. And when I finished graduate school, I set out to find medical practices where I could join them. And I went around the greater Seattle area and met a variety of different people and talked with them, pediatric offices and hospitals and primary care clinics. And I settled on one family medicine clinic where they invited me to join them. And it turned out to be 3 of the most rewarding educational years, professional years of my life. It was a small 2-person family medicine practice in the Ballard area of Seattle, where they shared their patients with me in their office space and their office function. And we shared notes and we talked about patients together all the time. And it was an incredible experience where I learned so much medical vocabulary and so much about the world of primary care and so much about what it means to be a primary care practitioner. And that's where I started for 3 years. And then I was invited to apply for the position at the University of Washington. One of the guys I was working with, one of the family doctors, was Bill Phillips, who was a part-time faculty at UW. He's a major person in the field. He was one of the founders actually of the Annals of Family Medicine and became one of the endowed chairs in our department. And he's always been a close friend and mentor and encouraged me to apply for the job at the university, where I then spent the rest of my career.
You know what's interesting about it, Larry? I think besides Chris Hunter, I think you and Chris are the only two people I've talked to that said almost from like the beginnings, like this was where you were going. This was, now, the one thing that I am curious about, and really interested, you know, as you said, having your family kind of background, and then you went into family therapy. Did anything draw you to family therapy? Like, what was it about family therapy that like really sucked you in?
Well, it's fundamentally it's the systems thinking. So, and not coincidentally, I mean that's the foundation of family medicine, right? Systems thinking, and so you know, it's always been apparent to me that there is a very rich interplay between biomedical and psychological and social function in understanding health, and to separate those healthcare efforts is very inefficient and possibly harmful. And intuitively, I think I understood that for a long time, and was excited to see opportunities to actually put the interplay of all of those kind of clinical services into actual applied clinical design.
It's fantastic, you know, and obviously with our talks before about, you know, systems or contextualism and stuff, it is just such a neat field to be in. And to see, as you say, all these different interplays, not only just with like patient systems and patient context, but literally like health systems and how those things interplay. That's neat. That's neat. Okay.
It is. Well, and you're doing some very exciting things in Yakima. I really enjoy watching what you guys are doing.
Well, thanks, Larry. We love, and I will say this to our viewers, Larry, I don't know if you want me to say this, but I'm going to say it anyway. You know, Larry maybe is one of the most giving people I've ever met. That he comes to Yakima usually once a year and talks with our interns and our fellows. So my mind is just saying, reach out to Larry, like one of the most responsive individuals that's out there. Again, I don't know if Larry wants me to say that, but I'm going to say it anyway. One of the most responsive individuals. So it's really been great. Now, you know, speaking of which, as you were saying about your role at UW, and this is something that I had no idea about really until I got my postdoc here at Central Washington Family Medicine, about this role of being a behavioral scientist. I think, and you've been one of the, obviously I don't know if it's the pioneer, the word that my mind goes to is about what that role means and how to go about that. Can you talk a little bit, one, about what the behavioral scientist role is, and then why you feel it's so important to, you know, integrated care, but even beyond that, to the development of family medicine physicians?
So, well, we've known now since the late 70s that the first place, from really good studies then, that the first place that most mental health problems present is the general medical sector, not the mental health sector. We've also known that managing chronic illness is a huge challenge from a behavioral perspective. So just thinking about the intersection of those two things, where do most mental health problems present and how hard is it to manage chronic illnesses, which contribute to 75% of our healthcare dollars, right? Which is where most of those dollars go. So integrating behavioral health and primary care has always made just logical sense, just from an epidemiologic perspective. The challenge in primary care, of course, is a manpower one, a resource one, and so it's always also made sense to me to help primary care clinicians and teams manage those broad psychological and social issues that interplay so intricately with the medical issues. And when I mean that, I don't mean just adding the role, the role of a behavioral health provider, clinician, but also helping the entire team understand how to include those skills in their day-to-day repertoire. So it's integrating not only role, but also function. So I've spent as much of my career helping doctors learn therapeutic communication skills and teams learn to function well together, medical and nursing teams learn to function well together, as I have trying to figure out how to integrate and make the best use of behavioral health clinicians in primary care. Does that make sense?
100%, Larry. And my mind has so many different follow-up questions, and I'll try to keep them. And we nerd out about this stuff, about what you're just talking about. It's not about just seeing patients as far as a behavioral health provider. It's literally about helping support the healthcare system, and that's training, and that's educating, and that's working with teams. And I love the fact that you use the word teams, and not just solely providers, right? That it's MAs, it's nurses, it's front desk staff. And I don't mean to simplify this, because I think a lot of times when you try to like simplify questions or simplify ideas, you don't get the greatest answers. But I am curious, if you were to train a primary care provider or a primary care staff member one thing, what would you train them?
Oh, interesting. I think what I would do is emphasize curiosity. We tend to want to too quickly go to a diagnosis and treatment, and forget that the human being that we're working with has a lot of knowledge. And to understand their view of the world increases the likelihood that whatever we prescribe, whatever we choose to do with them, is more likely to be accepted if it's designed in a way to fit. So early on in my career, I confronted the term non-compliance, which is the medical literature's way of saying they're not doing what I told them to do, which completely abdicates responsibility for understanding what people's belief systems will allow, and their cultures will allow, and what their personal resources will allow. But that's a pretty broad, term, and I don't mean in any way to denigrate or discount the value of the incredible diagnostic and treatment capacity that Western medicine has to offer. But person-centered healthcare is very important, and I think it rests on being curious about the individual's experience.
And I love the word that you use, curious, to increase curiosity. That is, I don't know, that is just really great. And this brings up, and again, my mind's going on so many different questions, but I'm going to ask them because we have time. So you bring up the point about patient-centered communication, which obviously you have been at the forefront of this. My thing is, interested, I feel like, and you all have done such good work at the UW of coming up with observation forums and evolving them. I don't even know what my mind's trying to ask. I think it's almost kind of like, how was that process for you all? Like, how was it difficult coming up with like how we going to objectively defined and operationalize what patient-centered communication is? Like, was that a difficult process for you all? What was that like?
Well, it actually, this comes back to curiosity. Back in the early 2000s, it became apparent to me that there are a lot of things that we need to blend into the skills that we teach primary care providers, not only how to effectively help patients be heard, but also how to manage time so that they can do it in a way without their own anxiety, the clinician anxiety getting in the way because they're under time. So I've always been interested in that, but there's a huge literature on communication skills that has been studied and documented since, way back when, the 60s and 70s. And I was fortunate enough in the early 2000s to join with a variety of folks, mostly from the Society of Teachers of Family Medicine, who were part of a group called the Group on Doctor-Patient Interaction. And we got together and we organized a way to study all of the major healthcare assessment forms. And we published a paper in 2005, which reviewed all of those forms. And it became obvious. So I learned a tremendous amount from doing that, as well as, having reviewed the literature. It became obvious to me that there were certain things that if combined in one single form could make a difference. And some of it had to do with some system assessment, but a lot of it has to do with understanding efficiency and how to organize time and make the best use of time. And so we developed the patient-centered observation form, and it's gone through many iterations, and now it's very broadly used, I think, in family medicine. So the answer to your question is, it's studying the literature, it's closely studying existing forms, it's coming up with a new model which builds on the existing work that other people have done. And that's always the way it is, right? Nobody has an original contribution. It's always on the shoulders of other people.
You know, and for those, again, that are watching, if you're not familiar with the patient-centered observation form, you know, you can access it for, and the one thing that I really like, Larry, that your team has done is that not only have you developed it for, you know, primary care providers and clinicians, but for MAs, for nurses, like really expanding this to what you were saying at the beginning, where this is a team. This is a team that is doing patient-centered communication. So that it is really just, and you have videos on it. It just, I don't know, you all did a great job with it. I know, obviously, our residency has used it for years, but hold on real quick. I'm getting interrupted by Bridget, who is interrupting a PCBH corner right now, huh? Getting headphones. All right. So, you know, you touched on something there that I wanted to go back to, or kind of go on to the next question, was this idea of kind of research and the importance of understanding the literature. And I will say, I don't know if I've ever told you this, Larry. So I remember there was a CFHA in Charlotte, I want to say it was like 4 years ago. And Jeff Ryder and we were given a presentation about an overview of the literature on PCBH. And I remember talking to Jeff before, and he's like, hey, Larry's coming to this presentation, like, we gotta have everything together. Like, we have to have this. And I remember it was probably, I mean, I always get nervous for my presentations, but it was definitely probably the most anxiety-provoking presentation I had done up to that point, where I saw you in the audience. I was like, oh man, we got to do a good job. So I think, though, it highlights, I mean, and this is what I always love about our conversations, because we always do eventually get to what is research saying. And you served, obviously, as the editor of Family Systems and Health. So I think I have two questions for you. The first one is, why do you think it is so important for, whether you're a clinician, whether you're in academia, whatever it is, for whoever's working in integrated care, to be so kind of on top of the current literature? Why is that important to you?
Because healthcare in general is renowned for using and advocating strategies that end up not being beneficial, costing more money, and in some cases doing harm. There are lots of ideas out there, and often we get so carried away with our own ideas or things that seem useful that we don't stop and think, is this really making a difference? And is it cost effective? Is it safe? And this is not just about integrated care. There are just, you know, myriad examples across all of healthcare, not just in mental health. So I think it's really important that we ask ourselves: is what we're doing making a difference? Is it added value? Is it making the best use of resources that we have? Is it making a difference for the populations that we're serving? That's why I think it's important. So it's very easy for people to get carried away with their own ideas and to sell them, and for people just to sort of follow them off a cliff without actually thinking, is what I'm doing now really the best use of my time? That's a pretty broad statement. And I don't know if you want me to get more specific or not, but. Well,
you know, I might ask you to get a little bit more specific, because, you know, I know, what was it, Larry? Was it two years ago when you wrote the editorial? And I think it was such an interesting time, and particularly about PCBH, right? About primary care behavioral health. And it was such an interesting time and it's still an interesting time, I think, for primary care behavioral health, and even what that means, and what is the research saying about primary care behavioral health. And the one thing that we have talked about regularly is that, you know, going around the country, talking with other people, getting to consult with other programs, and going on site, there is such a variety of what even primary care behavioral health is, and it is always that good question, like you're saying, like, since integrated care has been almost so uptaken and it's being so promoted right now, it has in a lot of ways just been like, hey, anything that you do as far as integrated care is good. And that, I don't know if that's true. I don't know if that's true.
No, in fact, it's definitely, you know, I think it's definitely not true. And I think I know the editorial you're referring to. So, the evidence does say that there are certain elements, irrespective of the model, that really make a difference. Primary care behavioral health is a very interesting term, and like in so many other cases, the name has now taken on bigger meaning. So primary care behavioral health, it's a model, but it's also a term that for many people, they don't really even know the literature. They just think, oh, this is behavioral health and primary care. And so let's just get out and do it. But there are some models, and the problems with models is that people sometimes get so engaged with just perpetuating the model, they don't stop and think, is this making, a difference? So that paper that you're describing made the point that that the proliferation of the PCBH model far outstretched, and still probably does, the evidence to support it. And you and I have talked a lot about this, that there are people who are rigidly adhering to a very limited number of visits, irrespective of how sick patients are, and that's irresponsible. And they're not monitoring, or they're so preoccupied, for example, with seeing so many patients that they're not doing the other things that are shown to make such a difference, which is documenting symptoms, documenting what they're doing, communicating with other members of the team, measuring progress. They're forgetting to do that kind of stuff because they're so interested in just seeing as many people as they can. So they're losing sight of the forest for the trees. And in a similar way, people also read literature and they say, well, this model, for example, the collaborative care model, only works because it's applied for people with depression. Well, common sense would suggest that actually there are a lot of things that transcend diseases. We know that most people who suffer from depression also have anxiety, and vice versa, and it goes beyond that. So certain principles that we've learned that transcend diseases, and people don't stop and think about that either. So reading the literature, I think, and really understanding it, and understanding how populations respond to usual care without added intervention is very, very important.
Larry, I couldn't agree more with you. And I think, and because I've seen it, I know we've talked about it, where even going to a health system and it's like, well, we implemented this model and we're not getting the results that we wanted. And it's kind of like, well, let's look at what you're implementing here. And as you said, it's like this rigidity of number of visits, how long visits can go for, what you're supposed to help with and what you're supposed to see. And it is one of those things that I think it's an interesting, I think it's a fun time, because like, as you said, there are things that we're starting to see that transcend these models and that coalesce, so we can really start to help programs implement. And let me, and I know this is, again, it's a corny as hell thing to say, but one of the things I've always admired and always appreciated about you is your willingness to say that. Your willingness to say maybe something that might go against, it might make a lot of people potentially like, well, what are you talking about? Of course, primary care behavioral health has like this research base. And of course, and I have always really appreciated that about you, that you're willing to have that discussion. It's not something that has been shied away from. So thank you for always being willing to do that.
Yeah, well, it became very apparent to me as an editor where I felt a real responsibility to monitor as a gatekeeper what got out of the literature. And there were just many, many publications that were submitted where people did not acknowledge usual care, and so they weren't comparing what they were doing to anything. And they didn't understand that a large proportion of the changes that they saw probably would have occurred had they done nothing. And there's good evidence to show that. So and this again is not new to primary care behavioral health or the integrated behavioral health world. Healthcare providers who want to promote what they're doing across all disciplines have been doing this kind of thing for a long time. And that's the reason why you see the promulgation of these very strong evidence-based organizations that are designed like the Cochrane Collaborative to assess evidence and make a difference. That's why the U.S. Preventive Task Force came into being.
Amen. Amen. Now, speaking of which, as being editor, what do you, thinking back at your time as editor, what were the most interesting or articles that you read or literature that you reviewed that made you, thinking back on that now, you remember those articles, or you remember that literature? Is there anything stand out? It's like, oh man, that was like a seminal piece of work, or it's like, man, we really thought we were onto something and then that got blown out of the water for research. I mean, anything that comes to mind as you look back on being editor?
Well, gosh, there's so many. It's hard for me to think about one because there are so many different articles, but I think you want me to respond to the dimensions just within integrated care. I think there's been a really good effort to publish some studies which take an honest look at what the components of integration are, and if those are associated with better outcomes. And I think, we published some of those. The PIP studies that Roger Kessler and his colleague Dan Mullen and others have done. I think those are some examples. I think that there are some studies that show that the size of a population that actually gets preventive care, the component of a population that gets preventive care, that gets assistance in managing their chronic medical illnesses, is increased by the addition of well-integrated behavioral health. That stuff I think is really important. So those are good examples. As we've already discussed, the studies that concerned me the most were those where the authors cherry-picked the literature, where they didn't take a bigger look at really what the literature showed, where they ignored, because they were so allied to a given model, they ignored evidence from broad population samples, which were overwhelmingly useful, just because they wanted to support a model. So those were the studies that concerned me, and I often either rejected or demanded that the authors change what they wrote.
And I think it's always this interesting thing, because I know I've been guilty of that, and a lot of times, as you said, kind of this cherry picking. It's one of the heuristics, right, that we're bound by. It's like, as soon as something fits my worldview, let's use it. If that doesn't, there's something wrong with that study, so I'll need to include it, right? And I do think, I guess this is almost my call to action for people doing this work in integrated care, even if you're a clinician, that there is such an importance of making sure that, one, we get the work out there, but we get the work out there in the context, in the system of including all these different components and making sure that we are being, as much as possible, we're always going to be biased, but as much as possible, taking an unbiased view of looking at the work that we're doing. for sure.
Yeah, and you know, one of the things that people often who are trying to write forget is writing a really well-constructed limitations section if they're doing research. And that's a very humbling but helpful thing to do. Why is it that what I've just presented may actually not be true, or may be limited in its application or generalizability? And a thoughtful a limitation section, you know, is sobering for the reader. And when you really think about that carefully, it should be sobering for you as a writer and cut back your tendency to want to promote. And I remember being, you know, seduced by this early on in my career too. Can cut back in your tendency to want to kind of overstep the evidence that you're trying to present, you know, overemphasize or oversell. And we're, you know, I don't want to get off on COVID, but we're learning that, as you and I were talking about before we started this recording, it seems like the evidence that we're learning actually is changing day to day. And I think it's obviously slower in integrated behavioral health and primary care, but the same thing is true.
Yeah, and I like the word again that you use, that humility to it. And I will say this is again another thing that I've always appreciated about our conversations, because you know, this is why I love sending you our data, because you do such a great job of kind of sending back. It's like, have we thought of this? Like, what else could this be coming through? And I think some of the interesting data that we're getting about our diabetes results is more about patient engagement, not necessarily about the behavioral health provider necessarily doing something that is really help, you know, like a one-to-one intervention of like, oh, the BHC, and then now their diabetes management gets better. It's more looking like BHC and their engagement with the health system goes up. So again, it is that curiosity, that humility to always be skeptical of even the stuff that, especially when it's exciting things, right? Especially when you get the results you want, to be really skeptical about that.
Yeah, we have to always be asking, what other explanations are there for this change, this success, or these failures? I learned early on that good research generates more questions than it answers.
Yeah, hell yeah. So let's, again, I appreciate you giving me so much time for this today. I have two last questions for you.
Sure.
The first one is, you know, if there's students that are watching this, and students being kind of behavioral health provider potential students, or early career professionals, or people that are later in the career but they're thinking about making a change to integrated care, what advice would you give them, and what would you suggest for them to do?
Well, you know, when you asked that, the first thing that came to mind to me was the first thing that I did when I had the mental health collaborative care, integrated care internship at the university for 15 years. And that was have those folks follow primary care clinicians in their day-to-day practice, so that they could really see firsthand what these primary care providers were dealing with, so that they could appreciate the intricate interweaving and interconnectedness of the psychological, the social, and the biomedical health issues that are presenting in every single day, every single hour in primary care, that they can see the challenges that primary care providers have, and that will, I think, give them a sense of what the patients need, but also how to best help the primary care clinicians. So, you know, as a integrated behavioral health provider, we have multiple customers. We have patients that we're caring for, but we have our clinicians and the team who we are there to help in a way that, you know, enhance their function. So observing folks for quite a while helps you develop relationships with them. It helps you empathize with them. It helps you think about what you can do. It helps you think about what you can do to help patients and the clinicians. So that would be, I think, one thing. And I think it's also important to recognize that every member of the team has their own sense of impotence, and to value your impotence in some ways, as a famous therapist used to say, psychiatrists, value your impotence in some ways as your most valuable possession. Don't go in there feeling like you have to be the person who has the answer to everything, and appreciate that the inadequacy that you feel is in its own way shared by other members of the team, and the fact that you guys can combine forces will help you guys figure out what those fears are and help one another address it and be more effective in meeting the needs of your patients. Beautiful.
Yeah, I like that second one. That's awesome. And you know what's I don't think it makes sense to me. The first thing that you were talking about shadowing and stuff, that's exactly what Jeff Ryder said on the PCBH corner when he said shadow. And I think it's a big thing that we don't talk a lot about for new providers and new students. And one of the things that you highlighted or you just said that really stuck with me is you develop an understanding of what the day is like for a primary care provider. So instead of it being like, oh, I don't know why people aren't getting me. Oh, I don't know why they're not giving me patients or handoffs, having an understanding of what they do every day, you're like, oh, it doesn't make sense for them to be the one to initiate. I need to be very proactive about this because of all the things that they have to do in their day. It really does give you that sense. I think it humbles you in a lot of ways. It's like, all right, I see what they're doing, and I know now how I can help out in a better or more effective way. That's cool.
I think so, and I think that watching a primary care clinician work allows you as a new incoming behavioral health provider to empathize with their experience. And if they feel your empathy and they feel your respect, they're more likely to trust you and share their patients with you.
They'll uptake it more. That's right. They'll uptake it more because they know you're with them. They know that's interesting.
Yeah, it's a big deal.
Now, the last question I have for you, obviously you've been in this for, decades as far as, and you've seen so many different evolutions, you've seen so many different iterations. As you think about like the future right now, like what is your hope for the future of integrated care? What is your hope for the future and the next iteration, the next evolution? What do you hope it be?
Well, I hope that the evidence catches up with practice, or the practice catches up with evidence. I hope those two images align, and I think that that's sort of the natural way of things. And in doing that, I hope that people, that the leaders who we have continue to role model common sense as opposed to an allegiance to a model that generates income or a model that is proliferating. I hope that those leaders and those role models and those quiet leaders develop the confidence and courage to ask questions in the way that they're doing about what they're doing, and to compare the evidence that they have in their own practice to the existing data about usual care, even though it may not come from their own practice, to ask the question, what do we know about settings where we don't do this, and is this really different? I think I'm hopeful that as integrated care continues to expand, that we start asking more about what are the core elements that make a difference, as opposed to wholesale delivery of models, because what we already know is that no model, no size fits all, and that you have to emphasize different pieces depending on the needs of the individual, and certainly depending on the needs of the population. And so how we put together our teams, not just in integrated behavioral health care, but in primary care in general, should be a reflection of what the needs of the population are, right? So you guys work in a federally qualified health center. Well, we know there that the needs of the population, the behavioral health needs of the population, are 2 to 3 times, if not more, greater than a general diverse primary care setting. So in that case, we need more behavioral health, but in other settings, there may be other things. So I hope that there are role models. I hope that we continue to study and ask questions, and I think we will. And I guess the last thing I would say is I hope that healthcare reimbursement continues to integrate financial structures that better support integrated behavioral health.
Amen. Amen. Well, cool, Larry. Again, I can talk to you for days. So I just appreciate giving some time today, joining us on the PCBH Corner. And as I said, I do want to end on this. That and again, Larry, sorry for putting this out there without you actually saying it. You're one of the most giving people I've ever met as far as the knowledge and the responsiveness. And if people are watching this and they thought about before, like, hey, I have questions for Larry, I'd love to get his perspective, so reach out. And I think that's a commonality amongst CFHA. I think it's a commonality amongst STFM, that these organizations, the leaders in these fields, they are receptive. So definitely do that. But thank you again, Larry, for spending time with us today. We appreciate it.
Well, thank you for having me. It's always good to spend time with you, David.
Thanks, man. So I was thinking that we can maybe talk a little bit about COVID. So, you know, my mind goes, I don't even know what the right question is. My first question was, what do you see, you know, and I think it's actually a cool thing that you're in kind of this, I would say, semi-retired kind of spot, because you have a cool vision, a cool view of what it is. What do you see the role of integrated behavioral health as far as helping deal with COVID?
Well, I think that we've already learned one important thing, and that is it's extremely likely that our frontline medical and nursing staff are going to be overwhelmed. And I think it's probably very important for our behavioral health providers to stand back and think about, what does this system need that I'm working in now? Because there's only so much skill-wise that we're trained to do in actually dealing with people who have respiratory distress and fever, et cetera. And so I think providing support is obvious, and it's very important. I think a second thing that we can do is buddy up with the people who have the responsibility to monitor how the systems are functioning and design them in a way that best meets the needs of the population and keeps the clinicians safe. And so our capacity as integrated behavioral health providers to think about systems is critical. It's absolutely critical. What do we do to make sure that, you know, we have a balance of providers? What do we do to compensate for a lack of expertise? How do we train? How do we think ahead of time about training others, cross-training others to step in when our core frontline staff is either homesick themselves or exhausted? And then third, I think there is going to be a significant component of the population who are suffering from panic and fear for good reason. Yeah. And there's a lot to be afraid about. And so to develop strategies for helping them. I'm reading a fair bit about this on the Collaborative Family Healthcare listserv. And again, people tend to jump too quickly to a model and forget that it's very, very important to be curious about each individual's risks and life issues. I mean, some people have a wide range of issues going on in their lives that contribute to their anxiety. And it's important to be able to identify those things as opposed to just apply, you know, sort of a blanket cognitive behavioral strategy, manage your thoughts. You know, we need to figure out what those individual things are. So, you know, I think curiosity about each individual's needs is also important. So there's a lot I think that we can do.
You know, Larry, and that last point, I was just having a conversation with someone else about this yesterday through email, and I think that last point is so telling. Like, talk about a context, or talk about a system right now where anxiety is rampant in, right? Like, I think we're all feeling that in so many different ways. And as you said, though, it's not like one blanket intervention is going to be useful for every single person. And I love the thing about that curiosity. And again, I think that's you're talking about this throughout, this humility that for us to have, which I think turns us to be curious about what is going on with people and our patients and even our providers. I know for me, you know, there's been, you know, conversations with different things over this past week with my teammates, and I'm sitting here scratching my head. It's like, well, why are you doing that? And then my mind immediately goes like, if you're asking yourself that, you need to be curious because there's probably a damn good reason why that is. I think that's huge.
Yeah, there's a lot of misinformation. People that is out there. People also aren't, you know, stopping to think about, you know, what they can do. And you know, I mean, there's also there's also really, you know, the question, what's the worst possible thing that could happen? Well, we're hearing stories about that. It's you know, it's quite a challenge, and we also have to, you know, recognize the limits of our power, you know, of what we can do. But being present, I think being members of a team and supporting the team effort really makes a big difference. And you know, integrated behavioral health providers have the capacity to do that. We need to think certainly well beyond just the needs of individual patients now.
And I love it. I'm going to end with that because that's what I've been telling people: be present. In any way, you know, it's not to say again, if things, you know, people are moving to tele and stuff, there's still ways of being present even through medicine. But I think that's the key thing is like, be there, be there.
Yeah. Well, you know, the good news about technology today is that it provides a virus-free way of providing care. Telehealth is a huge opportunity to make a difference that didn't exist in 1918.
Absolutely. Absolutely. Yeah. Well, again, Larry, I appreciate the conversation, man. Enjoy the day. Hopefully you're in Seattle right now, right?
We're in Seattle, but we're moving back to our cabin in the woods in north central Washington, where we're a little bit more separated from, at least physically, more connected with woodpeckers and trees than with people.
And I like that word, connected. So it was, again, so good to see you, Larry. Stay safe.
All right.
Thank you again for the time, man.
Thank you.